Doctors, uh, let me start by telling you what palliative care gave me. Uh, as I told you in the beginning, for about till I was almost 40, I had not even heard of palliative care. But once I came into it, I have a feeling that it gave a lot of meaning to my life. More than anything else, it liberated me. When I say it liberated me, what I mean is, till then, I had to turn away from suffering. People would be in pain and screaming in pain, and I had said meaningless things. Everything is going to be okay. Don't worry. Don't worry. The man is screaming in pain, and I say, don't worry, that's absurd. But that's what I had to do. But then I came across palliative care and I learned that I don't have to run away. When there are real problems for patients and families, I do not have to turn away. Instead, I can do something about it. I'm not able to solve all problems, of course, none of us can. But even then, I didn't have to run away. I learned to get rid of problems that can be solved and still walk with the patient and family when there was suffering that could not be relieved. So, doctors, welcome to this field, which will enable you and empower you. Some of you are already in palliative care. For the others, this will enable us all to face suffering that is caused by diseases. So, as Sridevi said, I am glad that there is this rich spread of people from so many institutions. I noticed that at least half a dozen are from Emmanuel Heart Association. We have associated for Emmanuel Health Association. We have associated for such a long time. Most of you are out there in the rural areas where the service makes enormous difference. So everybody, welcome to this program. The introductions on the first day, naturally, there are so many of us, naturally takes more time. So we have already lost 35 minutes. No, not lost, spent 35 minutes very usefully. So how long do we have? When do we have to completely finish and run away?
By 4:30.
So we do have almost an hour, certainly 55 minutes. So from tomorrow, we will have more time for discussion than we have today. But as we go along, if you do have questions, raise your hand either physically or electronically using your computer, and we will have interaction. Essentially, what I would want from you tomorrow, when I become a patient myself, if one of you is treating me, I want you to treat my suffering. Your medical education and mine has taught us to diagnose and to cure. Diagnose, cure. But not to look at suffering. Whether or not disease is incurable, we did not bother about suffering. This is my request to you. Treat my suffering, whether it's pain or other physical problems or psychological, social issues. Do what you can. This couple that you have seen on the screen, I don't know if any of you have seen this picture. They went to the High Court of Andhra Pradesh about 3 years back, asking for the court's permission to kill this child. At that time, the child was 4.5 years. That was not news. It became news when the court rejected the plea. We saw the news report saying that this child had advanced cancer, was in pain, and because they could not bear to see the pain, they want the child killed. Some of you are intensivists. I was an intensivist. Very briefly, let me tell you the story. We tracked the child to Hyderabad. A volunteer in Hyderabad took morphine across to which hospital the child was staying in, but found that the child had already moved, the family had moved to Bangalore in search of relief. The volunteer, having registered the child there and issued the morphine, took an overnight travel to Bengaluru. When there, found the child in the hospital. The parents were outside. The child was shut up in an intensive care unit. The child died a day after his 5th birthday, alone in an ICU, the father and mother outside, the morphine outside, without pain. What do you think about that way of handling a disease? The child had been living with cancer for 3.5 years. Lots of chemotherapy. This poor villager from Andhra Pradesh had already borrowed 16 lakhs, which he will never be able to repay. His family is destroyed. And all sorts of aggressive disease-focused care, which is all worthwhile if the disease could be cured. But even when it was clear that the child was dying, I believe humanity demands that the child should be in the mother's arms or the father's arms. The least that medical science could have done is to permit that touch. Not physical separation in an ICU. To what purpose? That child should be on our collective conscience. I know there are some 40 of you. You know the strength? True, in our country, 40 doctors learning palliative care is a small thing, but that's another step. Many of us will be able to relieve people's suffering. Let us hope that a few years from now, children like that will not have to die in pain, separated from their parents. Today's my introduction is about that child and people like that, and those parents and people like that. I know that there are at least 2 people in the group who teach public health, Department of Community Medicine or Social and Preventive Medicine. And you all must be teaching this, that health is a state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. Do you really believe this? Are you a healthcare professional? If you call yourself a healthcare professional, should we not be trying to do this? Not only diagnosing and giving curative treatment, but offering physical, mental, and social well-being. This is where a gap lies in healthcare. Huge gap, where we do not care about well-being, and as This is not only India, but much more in India than in Western countries. Next, please. Even today, even basic pain relief reaches less than 2% of people with cancer, and even much less for people with other kinds of pain. I know that the two people here are pain therapists, and you know what a rare species you are. So all of us have a lot to do to take at least the pain away, needless pain away from our people, millions of people. Next, please. A Lancet Commission on Global Access to Palliative Care, which published its report in 2017, gives that figure. Will you read that, what's on the screen? We have 1/6 the world's population. We have 1 crore people, approximately, in serious health-related suffering. And relieving that suffering is the joint task that we are taking on together as a body. We do not treat pain. That's one error of omission on the part of the healthcare system that I mentioned. Not only are we not relieving suffering, unfortunately, we are adding on to suffering. Oh, I'm not saying that healthcare is useless, by no means. Of course, we do remarkable work of curing a lot of people. That's tremendous. That's very much important. At the same time, by providing inappropriate end-of-life care, we are adding on to suffering. This report, which was published in 2015, you see the arrow? That's where they have marked India. They have marked India among the worst 15 countries in quality of end-of-life care. Only end-of-life care they are talking about. And there, India comes amongst the worst. And partly it's because we don't treat pain and suffering. Partly it's because we provide inappropriate end-of-life care, just as was done to that child. There are 40 people in the audience in various parts of the country. I don't know how many of you are able to think about your own death. Those who do not want to think about death, don't. I wish you immortality. But those who are brave enough to think about your own ends, please give it a moment of thought. Would you like to die alone in a great intensive care unit which is air conditioned with laminar flow of air and with 1,000 alarms and bleeps going all the time and like no difference between light and day, separate from the family? The family being allowed to come and see you for 5 minutes in the morning and 5 minutes in the evening, and even then afraid to touch you because your body is full of cables. I don't know about you, but for me it's very, very clear. If you are treating me, doctors, including the intensivists, if in your estimate, your assessment, my condition is not salvageable and treatment appears futile, please get me out of that ICU to be with my family, to maybe hold on to my son's hand, to say a final farewell to my wife, to hug my grandchildren once more. Those are the most important things. And we deprive that to everybody who has some money in the pocket. In our country, the poor die better. At least they will have a few drops of water going down their throats when their throat is parched. The rich yet only a suction catheter that causes pain. This is an error of commission on the part of the healthcare system. And the other error of commission is this. Read that statement again. This came out in British Medical Journal in 2018 May, just 2 years back. Like most doctors, I am very bad at math, so I had got a friend to help me and estimate 55 million works out to more than 4% of our population in 1 year. And this is a growing expense. Every day the newspapers are full of the cost of COVID treatment. And we are all worried. We are, especially in the last 5 to 10 years, we are people attacking doctors. Look at that figure. Well, I am glad that at least palliative care is low cost. You don't require gleaming expensive equipment. True, inexpensive morphine is usually not available. 150 times more expensive transdermal patches are available. That's a system issue. We need to solve that also. Next, please. Let us, before we move away, dispense with some myths, some misunderstandings. I myself was talking about that child. I was talking about end-of-life care, but by no means take away the feeling that palliative care is only for the dying. It most emphatically is not. So when I am your patient, even before you are able to diagnose my condition, I may be in severe pain. I hope you will give me palliative care from that moment. I'm not saying shift me to the palliative care center. No, no, no. Wherever you are treating me, you incorporate principles of palliative care into your routine work. The oral surgeon, when you are looking at the lesion, also take into consideration my pain and suffering. That integration of palliative care is what we need. This is how the WHO defines palliative care. No, Rajalakshmi will let you have the whole presentation. She will send it across to you. You can read that long definition at leisure. But look at a few phrases that I have marked in a different color. Your medical training and my medical training was concentrated on disease. Here we talk about quality of life. Certainly disease needs to be treated. Along with that, quality of life is important. And see, I have marked the families. Every one of you who has gone through a family member in serious disease knows how much the family member suffers. The family member whom we call bystander and try to push out is suffering enormously. And in these COVID days, already 11,000 people have died. What's happening to their loved ones? At least another 33,000 people would be living in pain and suffering, not having been able to see and one more look at their loved one. Are they not suffering enormously? Family suffering matters. And for this, we have to prevent and relieve suffering. Suffering can be any of those, pain and other physical problems. Breathlessness, punctuating ulcers, just body aches, anything. Suffering that is psychological, depression, anxiety, guilt, social, including the isolation that we inflict, but also stigma against diseases, the financial destruction. That's all part of the social issues and spiritual issues like what's the meaning of life? Why is God keeping me still alive? I wish I were dead. These are all elements of suffering that we need to identify and do what we can. We cannot take away all suffering, I repeat, but do something about it. And even if something cannot be relieved, never abandon patients. They need a hand to hold. Earlier, I mentioned that palliative care is not only for the end of life care, and in the new, as a footnote to the new definition of palliative care, WHO adds that palliative care is applicable early in the course of illness, in conjunction with therapies that are intended to prolong life, along with that. And it is not only for some diseases, it is cruel to discriminate in the name of a diagnosis. I may be only having COPD, but if I am not able to breathe, should I be denied care? That's what happens in many places. In many major cities in India, some palliative care is available for people with cancer, not for anyone else. There is a huge injustice in this. This is not disease specific. Suffering is what we treat, irrespective of disease. In 2017, a Lancet commission came out with this phrase as serious health-related suffering. The WHO definition that I mentioned is 18 years old. It has not been revised. So they highlight the point that palliative care should be for any serious health-related suffering, aimed at quality of life. Yes. To explain what I have in mind about treatment of suffering, let us think about this person coming to you with breathlessness for advanced cancer. Can you blind the screen for a minute? This person, I have deliberately blinded the screen. Oh, it's still there, sorry. Can you go back one slide? Yes. No, just leave it there. A person with advanced cancer is coming to your emergency room. Gasping for breathing like this. Maybe even turning blue a little bit. You know it is advanced cancer. You know that it's an incurable disease. My question is, where would you treat the patient? I know in those work, I know that one of you is working or was working in Max Hospital. The protocol there, I fear, as soon as the saturation is shown to be 89%, will be straight a passage to ICU. Whereas in Emmanuel Heart Association, I'm sure that's not happening. If I am the patient, if you had the decision-making capacity, where would you treat me? I've come to the hospital, I'm seeking your help. Would you treat me in an ICU if my oxygen saturation is less than 90%? If I am very breathless, what would you do for me? Would somebody like to speak up? They would have a electronic raise hand option on the computer. Would you like to tell them where to find it?
You can search in the participant list. Inside the participant list, there is an option of raise your hand. Or you can unmute yourself and speak. Yes, Dr. Abhishek.
Yes, sir. when I see that some patient is coming in that condition, um, he is coming inside the room. I just everything will start accordingly. I just tell the patients that relax. I am putting a oxygen mask to you, and you will start. First, you will have some problems to breathe. Then, accordingly, you will get a relief. Don't panic, because if you go on panicking, you will have some. You will invite the problem more and more on up to you, as well as the outside other persons who are helping me. I will tell them just help the patient to breathe calm and quietly, give time. These things I can start, and I think in that way, if I'm wrong, sir, please correct.
Dr. Abhishek, thank you. Thank you for that input. Yeah, essentially, you are recognizing that I am suffering. Good. Because I need that personal attention.
Yes, sir.
Thank you. I have some slight modifications to the way you handle it. One thing is, you are going to give me oxygen. I have advanced cancer. The oxygen may help me, it may not help me. If the problem is that a bronchus is completely blocked, giving oxygen from here will mean that only a tiny part of it will get into my lungs. And if my lungs are badly diseased, it may get into the lungs but not into the blood. So a lot of people will be helped by oxygen, some people will not be. And those people who are not helped by oxygen is the people that you see trying to pull the mask away. Because if the oxygen is not helping them, it's a barrier. They were already unable to breathe, and then there's something preventing communication like that. So I will also use oxygen, but I'll tell them, this is only if I know what's the problem is. I am under the assumption that we know it is advanced cancer. We know that there is no curative treatment left. Everything has been done, and the person is having advanced problems. In that case, I will tell them, I see you are breathless. Maybe you are also scared. Dr. Abhishek, instead of saying don't panic, if you panic, your problem will be more. Instead of that, I will say, I see you are scared. I am going to look after you. I will do my best to make you feel better. Then I will feel, oh my God, in this big hospital, there is one person who truly cares for me, Dr. Abhishek. I will hang on to you because you reassure me. That's real reassurance. It is in saying you don't panic. Nobody panics by choice. I don't have a choice. The fear is coming uninvited. You take the fear away by giving me honest information and by assuring me that you will look after me. So I will tell the patient and family, I am going to put oxygen on. How long does it take to achieve equilibration between inspired air and blood? At most, it takes 7 minutes. Most of the equilibration happens in 3 to 4 minutes. In 10 minutes, you will know if the oxygen is helpful or not. If the oxygen is not relieving the dyspnea, it is not helping him. If you take it away, he'll be so much more comfortable. But the family will be saying, why are you not giving oxygen? So even in the beginning, you tell them, before we do it, I'm only teaching what I practice. When I tell them in the beginning, because he has this problem, he may be breathless. If oxygen helps, we'll continue them. If it doesn't help him, he will find it a trouble, then we'll take it away. And people accept it unless there's a doctor in the family. If there is a doctor in the family, they cannot accept it. That's what usually happens because we have had it deeply embedded in your psyche that every person dying should be dying with an oxygen mask. So can I put in the next one now? What I'll actually do is, I look for any correctable cause. I will not assume that the person is dying of cancer. Maybe he has a pleural effusion. Maybe he has an infection. Maybe now he has severe bronchospasm. I will look for correctable problems, correct it if possible. But I will not take him to the ICU. A person with advanced cancer should not die on a ventilator. That's cruelty. That is not science. Everybody possibly should read the guidelines from Indian Society of Critical Care Medicine, where the position statement and guidelines are given. And no science dictates that every person with advanced cancer should die on a ventilator. It's adding problems. I will give oxygen if it helps the person more than everything else. What Dr. Abhishek did, calmly standing there, he will look after you. If it is possible in your setup, say, one of us will stay with you till you are feeling better. That will be real reassurance. But promise only what you can deliver. If you are unable to have one person stay there, just say, we will come every few minutes frequently and check on you. We'll try our best to make you better. And never promise impossible things. You will lose trust. The medicine that may help in an advanced malignancy is corticosteroid. Wherever there is tumor, remember this. This is not only for breathlessness. The same thing may hold true for intestinal obstruction. Where there is tumor, there is peritumor edema. The obstruction in the bronchus will be because of the tumor cells and the edema around it. You reduce steroids, the edema reduces, and even 1 millimeter opening of the airway will improve the airflow by 16 times. All the anesthetists and pulmonologists know this. Flow increases 16 times the diameter of a tube. And finally, though we were all taught at one time that morphine is contraindicated in breathlessness, in dyspnea, long back, I was asked that question in my MD exam. Today, we know that morphine can be the drug of choice in breathlessness, whether it's advanced cancer or advanced COPD. By decreasing the sensation of breathlessness, low-dose morphine helps. We'll talk more about it on another day. Okay, I brought in only one symptom, and the purpose of that was to demonstrate how, in the context of an advanced illness, management changes from what you learned in Bailey and Love or in whatever textbook of medicine you are studying to palliative care. You have, towards the end of life, you suitably adapt the management. So, doctors, when I come to you, I certainly want your knowledge. If you are not knowledgeable in the subject, I don't want you. I'll go to somebody else. But if you are only knowledge, if you are so full of brain that your brain has compressed the heart, I would be very unhappy. I want your skill, but also your compassion. And the difference between a medical technologist, medical scientist, and a doctor is having this addition of compassion and skill in the handling. And that skill is not only in poking needles in, but also in holding a hand, wiping a tear, and talking gently and reassuringly. And towards the end of my presentation, I will remind you that as the Emmanuel Hospital Association doctors are doing, as far as possible, according to the Astana Declaration of 2018, pronounced by global nations, the public health people will all know this. They, as they advise, care should reach people where they are, when they need it. Where they are, when they need it. When they need it, we are still not able to do. If somebody calls in an emergency at the middle of the night, we are still not able to provide home visits, but at least we try to reach people where they are. That's in their homes, if at all possible. And in the beginning, I mentioned the family. We'll remember that. Palliative care is not only for the patient, but also for the family. Family can be in serious trouble. They may be burned out. They may be in depression. They may be in guilt. They may be in anxiety. A few minutes spent with a family member, just acknowledging, we know this must be difficult for you. We'll do our best to help you. Here is our number. You don't promise to take the phone yourself. You can't do it 24 hours. But here's the number to call when you need us. We fortunately are able to give a number which is available 24 hours. But even if that's not possible, just say what's possible. This, you can call on this from 10 to 5. Whatever we can, we tell them. We also empower the family in care. See, think of what's ordinarily happening in hospitals. They are in hospital, we do the medical management, we do the nursing, nurses do everything. All of a sudden you discharge them and the family member has to act as a nurse. You just say turn him every 2 hours. You are not even usually demonstrating how they are to be turned, how to care for the skin. So empowering themselves itself is part of this process. And we will not forget children or families. We talked about families. Usually you think only of the spouse, main caregiver. Usually you forget children. Children are the unseen martyrs of disease and treatment. I told you that 55 million Indians, according to that British Medical Journal article, are pushed below poverty line every year. What happens to them? Well, we look after them. We make sure that even their education is complete. This we can do if you're just not an organization, but not just a hospital, but an organization where we can engage the community and make sure that these things are done. Next. Very often, in the beginning, I said palliative care should be from the beginning of the illness, right? When we talk about it, people suspect that by giving morphine and medicines like that, we are actually reducing the lifespan. Far from it. We are actually possibly prolonging survival. This landmark article, which was published in 2010, compared two groups of patients with non-small cell lung cancer. One got only chemotherapy, the other got chemotherapy along with palliative care. And the group who got both lived by an average of 3 months more. They had better quality of life. Most of them died at home, not in hospital. And their general quality of life was better. We try to work with the individuals and organizations who want to develop palliative care units. I'm just showing that I am only giving the overall introduction today. We'll go to specifics later. But if later on anybody needs help, advice, how to start this. I am having this problem. How do you overcome them? We cannot get morphine. How do we make morphine available? These are problems that we can work with you. We can help you to sort things out. That's part of our mission. Never hesitate to ask us. Next, please. I am almost ready to conclude. But before concluding, let me tell you that palliative care delivery is by 3 means. At the end of the course, I will keep you in the middle. I am one of those. Generalist palliative care. I also have undergone only a few weeks course in palliative care. I'm not a specialist. I don't have an MD or an MRCP or something like that. But even if you do not have that, the oncologist, there are oncologists in the group. You will be so busy. Oncologists, pulmonologists, you are going to be so busy with your own specialty. But when, along with your oncology practice, you also ensure that pain medication, pain is asked for, looked for, and medication is given, you are using the palliative care approach. When during your evaluation, you are also looking the patient in the eye and telling them, you look a bit anxious. We are going to take good care of you. We'll do our best for you. Then you are using the palliative care approach. If you also have somebody outside there, a nurse or a social worker, who sits down with the patient and says, what are the major issues that I see in your eyes? Would you like to talk about it? Then you are using the palliative care approach. We can have palliative care units, but the palliative care approach is something to be practiced by every doctor, every nurse, every person in the hospital, including the security person at the gate who welcomes people with a smile. Because we spend a little too much of time in the beginning, I may not have time to go through that illustrative story, which if we find the time, we will do it on another day. I see that we have only 16 minutes left. So I'll stop with that and reserve the rest of the time for the discussion. Sridevi taking over. Sri?
Yes, sir. Yeah. Thank you so much for the presentation, sir. Raju, can we take up a few questions?
Yes, ma'am.
Either you can raise your hands so that we can see it on the screen, or you can raise hands. There is an option down on the right end. You can raise hand, or even you can type it in the chat session so that we can read it aloud and come back to you.
Sri, a couple of people said the connectivity is, the audio is broken, etc. Did everybody have a problem with our audio?
No, it was not the case.
Okay.
And some people were not able to see the screen that I fixed in between. I told them how to manage that. But audio, I think everyone, I should hear from them.
Okay.
It was clear from my side. It was absolutely clear.
Ma'am, I have asked a question in our group. So everybody responded they could hear it. So maybe it is because of their bad connectivity, they are not able to hear us.
Sri and Raju, towards the end, when they send the feedback, there's one thing that I would like to ask everybody. Would you have found it possible to attend it? Not this time. It's for the future courses. If there were 2 courses, 2 days a week session, instead of 18 weeks, we could finish everything in 9 weeks. Would you have found it convenient? Second question is, what time would have been most suitable for you? We cannot suit everybody's convenience, but maybe 3 o'clock is not the best idea for many. The majority feel another time is more convenient, we could consider that. So that's not for the purpose of this course. To guide our future courses, please try to answer these 2 questions later.
Dr. Taranjit, you had a question, ma'am?
Ma'am, I wanted to ask, can you hear me?
Yes.
Ma'am, I wanted to just have your opinion about whether we can start with the palliative care in patients who are not willing for further treatment because of their financial situations, because they cannot afford to have those costly chemotherapies. So can we start with the palliative care in between?
Karanjit,
Like a patient of lung cancer cannot afford to have chemotherapy. Can we just ask him to stay at home and have oxygen therapy from wherever he can have, or have chest drainage again and again for pleural effusions? And will that be on the answer to them?
Karanjit, what is your own answer? What do you think? What do you think is the right thing to do? The patient says, I cannot, no money. It's okay. I mean, my fate, I'll go back home. What do you think we should do?
The
What
government
do you-
should be participating in for giving them free treatments. I mean,
Okay.
there should be some
There
availability of
should be.
money, or there should be some common pool from where we can give them free treatments. Because these patients are the ones that we feel that they can be helped by chemotherapy, but only because of money, they are not able to get that treatment.
So, Karanjit, yes, tomorrow let us all hope for a day when all treatment is given by the public health system up to a point, like in Western European countries. We are not there yet. So, to answer your question, what we should not do is to abandon them. Instead of saying, if you can't afford the chemotherapy, why are you coming to me? You go. That is cruel. So if that's not possible, we will do the best thing for them. They must get palliative care. Absolutely no question about it. Even if they are having chemotherapy along with that, palliative care should be available. That's what I was saying. But certainly, everybody should have palliative care. And that you may not have facility to admit them for palliative care. So you will give the appropriate medicines for them to take at home, which is what we do to all our patients. But we are able to provide home visit for them at least once a week or once in a fortnight. You may not be able to do that. You may be able to treat them only over the phone. We do that for people coming from other cities. We prescribe the medicines. The patient will not be able to come. We do the best for them over the phone. Allow a family member to come and collect the medicines. We may use a mobile phone to talk to them or even to see them. These are things that we do. So, Karanjit, yes, absolutely. They must have palliative care. If there is no other possibility, they will. The best possibility is their home. We will have palliative care there.
Thank you, sir.
Thank you, sir.
Sir, there are a few questions in the chat. We'll discuss the timings later in your WhatsApp group. Today, we don't have much time, so we'll stick on to the questions related to today's topic. So there was a question, how do you see palliative care to go forward and what are the challenges? That is the first question.
One major responsibility that all of us will take is to be the patient's advocates. There's a lot of injustices happening out there. People being denied care, people giving inappropriate care. You are all on this course because you are people who care. I think we have a responsibility to do more than treating that patient that Karanjit was talking about. Maybe we can write about it. Maybe we can get together and do it. Many of you will be invited to television shows, newspaper reports, etc. We need to be the patient's advocates. Some things are happening, doctor. Who asked that question? Sorry.
Dr. Deepak.
Dr. Deepak. Some good things are happening. In 2012, India formed a national program for palliative care. Not funded adequately, so not much happening, but it is there. The new National Health Policy of 2017 mentions palliative care. The Medical Council has introduced most of palliative care into the curriculum, at least from 2019. So many good things are happening. And they are happening because there have been people going to the government and asking for it, not for ourselves, but for everyone. And that has helped. So it's collective action that will change things.
Deepak has asked one more question. Like when they go for other services and many traditional medicines or something, how do we prevent it? Or how do we tackle that?
Doctor, we cannot prevent all injustices. If we start fighting everything, you will get tired. We choose the battles that can be won. What you can do at the least is make your service available. Give the people the choice. People may not take it, but there are these millions of people who need care, and many people will come to us. Then how is Emmanuel Hospital Association doing all these things in so many places? They became known for the good work that they do, so more people will flock to us. In the first month, you will have 3 patients, but in the first month of the next year, you will have 30, and the subsequent year, you will have 300, and you won't know how to handle them. It will happen. Tackling a question from Dr. Guhan. Tackling family members are more difficult than the patient as such. How do you manage? I mean, when we talk about communication, we'll talk more about it. First, I recognize that the family member is also suffering. There will be some nuisance from a distant relative wanting to act prominently and coming and fighting. But the majority of people are very much suffering. And there will be problems. There is not one solution that will fit in on. But first, recognizing that they are suffering is a step one. They are not our enemies. The family members are our partners. We need to work together if the patient's quality of life is to improve. And they have to look after we have to look after their quality of life also. So, when I, in my mind, consider them partners, half the problem is over. I try to listen to them. There are times when the time is limited, and I may have to say, I see that you have many questions. Today, I have only 5 minutes more. Ask me the most pressing question in your mind. Let us tackle that, and we'll deal with the rest next time. Generally, by acknowledging their suffering and working with them, most of the time we are able to work well. Sometimes there will be problems. In medicine, anyway, you are not always successful with everything. There will be difficulties at times, and especially the angry patient. I mean, during sessions on communication, that will be particularly discussed. How do you deal with somebody who is angry? Those are things that we'll deal with in detail.
Dr. Bijli has asked about, can palliative care and disease modifying treatment can go hand in hand? Why should we separate?
Absolutely. That was one of the main things that I wanted to convey. I did try to convey. I see that I did not convey it effectively. The palliative approach that I talked about is concurrent palliative care along with disease-specific treatment. So if it is cancer, no one can give palliative care better than the oncologist. That doesn't mean that he stops his oncology practice and goes and sits in another OP. But from the time the patient comes to them, in the limited time available, that doesn't mean that he can spend an hour with every person. But with the time available, the palliative approach is integration of palliative care principles, symptom control, psychosocial support, all along with disease-specific treatment. And during communication, we'll also talk about what to do when there is limited time, how we can handle that.
Sir, there are more questions coming. Today we have planned for telling them a model how to do a presentation patient story from next week onwards. Should we take up more questions, or because we have 5 minutes? So I'll do a presentation just to show them from next week onwards, how are they supposed to manage those presentations?
Doctors, I know there are several questions. Raju, you must give me the questions and we'll send out the answers to all of them. But also, we are going to deal with all this in detail later. This is only an introduction. So I'll hand over to Sridevi for the instruction that you wanted to give.
I will just go through a presentation, patient story that we have managed. So this is a model by which you may have to do it from the coming weeks onwards. So this time we are doing it from our side so that you can just get familiar with the presentation and what are you supposed to do. So this is a story of a 40-year-old female with juvenile diabetes, diabetic retinopathy, and there is a diabetic ulcer on the left foot with coronary artery disease. And she came with increased blood sugar. There was an ulcer in the plantar aspect of the left foot, and she had a visual impairment, and she was waiting for a cataract surgery. She had diabetes, which was found out 3 years back, and she was on OHS, and she was taking insulin, and left toe amputation was done, and she had an atypical chest pain in 2016. Next, I'm just reading the relevant part of it, sorry. So on examination, blood sugar was really high, which was about 400, and all the other systems were normal. And her vision was really impaired that she had to strain a lot to see what is, to check the messages or phone numbers in the mobile phone. And there was an ulcer in the left foot, which was quite deep, but it was clean. Next slide. And this was the significant investigations, and there is nothing much to explain in terms of treatment which she has already undergone. She has undergone a cataract surgery on 25th April 2019. Her vision was improved. So after admission, she was admitted at our center, and the blood sugar was controlled, and the FBS became 73 now, and vision was improved after the cataract surgery, which was happened after the admission. Next slide. So this is about her aspects, who she is, where she belongs. She lives with her son, who is 13 years old. She was married, and her husband left her in 2018. They live in a very miserable condition. There is no bed or no privacy at home. Very, very poor financial background they come from. There is no support from anybody. It is just the mother and the 13-year-old son, and the 13-year-old son is a primary caregiver for this mother who has who had a lot of visual impairment. They didn't have a facility to store insulin, so although the insulin was prescribed, she was not taking it because there was no facility to store insulin at their home. Next slide. So these were the medications that she was on: insulin, statins, and isosorbide dinitrate, and clopidogrel. So this was the main concern. She had this illness. She had lots of disabilities in terms of taking out her own activities of daily living, and there is no one to support. It is just a 13-year-old son who is there to take care of her. This was the main concern. So this story is about a 40-year-old female with diabetic retinopathy and a huge ulcer on the left foot with coronary artery disease. So in the end of the slide, you have a provision where you can ask your questions or the things that you want to discuss among ourselves, and find out what can be done, or is there anything more to be done. So in this, the patient's main problem is uncontrolled diabetes. Does this patient actually come under the purview of palliative care? Does she actually need palliative care? And what all things can be done to improve the quality of life of this patient? And regarding the 13-year-old son, is it our responsibility? Do we actually need to take care of the child? Who is the only caregiver for her right now? We don't have time. We are not going into details of management of this story right now. But this is the way it should be done from next week onwards. So according to the topic, if the next topic will be about pain, then if you can find a patient story whom you found during your practice with pain, so you can send it to us and we can discuss among ourselves. This is not about finding answers or finding faults. It's about you learning from us, we learning from you. How do you manage? What were the issues? How can we manage in your setting? So this is about mutual discussion and learning from each other. So this is what we expect from next week onwards. And one question in the chat was there, people who could not hear it properly, we'll be sending a YouTube link where you can you can listen to the entire presentation anytime you want. So we will be sending a YouTube link and some learning materials and sir's presentation after the session. Every week you will be getting all these things, a presentation of the faculty, the discussion, and you will get learning materials and YouTube link. Raju, sir, we will not be doing the discussion based on the story, but before we leave, if you would like to conclude the session, because it's 4:30 now.
Its time is up. I think we have to stick to the time. So I'll repeat. Raju, I'll leave it to Raju to collect the feedback from you. I would like to know, apart from the usual feedback that you will be asking for, whether you have found it convenient to have 2 sessions a week, and whether the 3 p.m. to 4:30 p.m. is the good time for you. If not, what would have been a better time? And I repeat, that's not for changing this course schedule. That's for our guidance for the future. And I'm just requesting your help by giving your opinion. And thank you for patiently listening. From next time onwards, because we will not be spending that initial 35 minutes of self-introductions, we will have more time for interaction and for discussions. I'm glad you are all here. I hope this is not the end of the session, though this is the end of today's session. I hope this is also the beginning of a long-term association.